Welcome to this session on data analysis and query building with MedDRA. As Leander said, my name is Jane Knight and I'm a clinical associate with the MedDRA MSSO. The first slide explains that MedDRA came about in the mid-1990s. It was an ICH initiative, and at the time, the MSSO, who we both work for, were put in place to maintain and distribute MedDRA. The activities of the MSSO are overseen by a management committee, a steering committee it's now called, which has representatives from across the ICH regions, both the industry and the regulatory authorities. And you've got some of the members of that committee on your screen. The second slide is a disclaimer. You may have seen this before with some of our materials, that this shows that ICH owns MedDRA and in turn owns the material. So if you quote the material, you're welcome to use it, but if you reuse it, you must acknowledge ICH as the owners. And if there are any third-party slides that we've received from other people, then you can't assume that you have their permission to use those slides. So that's all the preamble out of the way, and then the overview of what we're going to cover today is we're going to discuss topics in the MedDRA data retrieval and presentation points to consider document. We'll discuss applications of MedDRA in data retrieval, presentation and analysis, and discuss and demonstrate the use of MedDRA for developing queries. Now, and I'll explain what a query is later. And this is the first webinar. Really, there's a follow-on webinar, and I could say it's one of two. The second webinar is next week, and in that session, we will look at standardized MedDRA queries. So today we're going to look at how you build your own query. That's really if there isn't a standardized MedDRA query or SMQ. So just bear in mind that there will be a follow-on to this webinar, and if you haven't signed up for it, you might want to look to do so. So having covered all that, I'm going to switch off my camera because I know it can be distracting for you. So I'll switch it off and we'll get going on the active material. So MedDRA data retrieval and presentation points to consider document. So this document provides data retrieval and presentation options for the industry or regulatory purposes. You see there options. So it will explain the features of MedDRA that can be useful for presentation, retrieval, analysis of data. And this is what we're going to look at today. The document is most effective when used in conjunction with its sister document, MedDRA term selection points to consider. That's the one that people are probably more familiar with. It's a coding guidelines document. And it's logical that if you don't organize your data systematically using consistent coding conventions, then it's going to be more difficult for you when looking to retrieve or see patterns in the data. So that's what we mean by saying that this document should be used in conjunction with the coding guidelines in the points to consider document. And then the third bullet point explains that it's recommended that you use this document as the basis for your individual organization's data retrieval conventions. I can show you later on the website where to find the document, and you'll see that it's available in a number of formats. This is so that if you wish, you can take the document or sections of the document and add it into your own SOPs. And we see there the date on the document. This is the front cover of last year's March 2025. And this is because, as we see here, it's developed by a working group of the ICH Management Committee, or Steering Committee, that should say. It's updated annually in March, and the complete versions of the document are available in a number of languages. There are also condensed versions in some other languages, but MedDRA is now available in a lot more languages. We're currently on 27 languages of MedDRA, and so some of the more recent languages of MedDRA don't have a version of the points to consider document. So just bear this in mind. Depending on which translation of MedDRA you're using, there may not be a copy of this document at this time. The Points to Consider document is available on both the MedDRA and the JMO websites. The points that are addressed in the document. So firstly, there's a section which covers general principles, and these are the quality of source data, documentation, what you should document, the guideline do not alter MedDRA, understanding your own data, and the characteristics of MedDRA, then versioning. And I'm going to cover these now one by one. The document goes on to talk about what is a query, and that's what we're going to do in the second half of this webinar. And then, as I mentioned, we have standardized MedDRA queries, which saves us all a lot of work in not needing to build our own query. If it is one that is commonly needed, there will be a standardized MedDRA query in all likelihood for it. And also, so we'll cover that next week. And next week, we'll also look at customized searches. So the first principle when thinking about data analysis retrieval is that high quality data output is dependent on maintaining the quality of the original information reported. And this is what we've already mentioned. Refer to the MedDRA term selection points to consider document to ensure your coding is high quality, consistent, and accurate. The second point to consider regarding the quality of your source data is how did those data get put into MedDRA in the first place? If your organization goes back many years, you will find that before MedDRA was in place at the end of the 90s, other organizations were using other adverse reaction terminologies, maybe WHOAT or COSTART. And at that time, the organization needed to take their legacy data and convert it into MedDRA. Now, there were two ways of doing this. They may have taken the original verbatim terms and coded them one by one into MedDRA, or they may have taken the dictionary term from the legacy terminology and matched that to the closest equivalent term in MedDRA. Now, that would be a fine approach, except the legacy terminologies were much smaller than MedDRA, and the dictionary terms in them were more general. MedDRA is very large, and it has many, many more terms available. So consequently, you would have been taking a term like infection, for example, a simple term which captured all infections, and converting this to MedDRA, without actually considering all the individual terms in MedDRA which have types, pathogen terms, specificity, the location of the infections. So by doing that batch move, then you wouldn't be maximizing the specificity of MedDRA when you do your coding. So this is something to be aware of, that very old legacy terms that your organization may have received may not have been coded to the best place, depending on which legacy conversion method was used. Okay, I hope that makes sense. If anyone's got questions on any of this material, send us a comment and Leander can stop me and we'll explain a bit further. The next principle is about documentation of your data retrieval and presentation practices. Now, I sometimes think it's a good idea to think about, if you were to be audited or inspected by a regulatory authority, what kind of documentation might they ask for? And think about this. So you want to document your own organization-specific guidelines, whether that's SOPs or other work instructions. Make sure that your own guidelines are consistent with the points to consider document. Document your coding conventions. Document your data retrieval and output strategies, including how you use the standardized MedDRA queries that we're going to talk about next week. Think also to document your quality assurance procedures. Versioning is important, so you always want to make sure that you document the version you've used for building your queries and performing your searches, your search strategy methods, version update processes, and as we'll see later on, the processes for customized MedDRA queries, how you might take an SMQ and adapt it, or how you build your own query, as I'm going to show you today. So it's useful to have these things documented, as I say, or not just for inspections, but also because people move on to different roles, they move on to different projects, and it's good practice that you could hand over to somebody coming into your role if you were to move on. This is a very important slide now. The principle is do not alter MedDRA. MedDRA is a standardized terminology with a predefined term hierarchy, and users must not make any ad hoc structural alterations, and this would include changing the primary SOC. So when we code, we always code into the primary SOC. And if you find when you come to do analysis, you see that those reports are spread across multiple preferred terms or system organ classes, if they're accurately coded, that's fine. You mustn't change the SOC to group them together or based on what you think is going on behind the scenes with that patient or with your drug. If you think a term, however, is incorrectly placed, please submit a change request to us at the MSSO, explaining your rationale, why you think it's in the wrong place, and proposing that we move it perhaps to a different preferred term, different HLT, different SOC. Next thing to be aware of is your organization-specific data characteristics. So when you're planning a retrieval strategy, it's useful to know your own database structure, how you store MedDRA, how you use the hierarchy, and what levels of terms are stored. Whether you store a synonym list, whether you store the reported terms, and the levels of MedDRA that you use. So these two top points, I'll give you an example of this. I used to work in the industry, and I was working on a product which caused, it had an immunosuppressant effect, and the patients were immunocompromised. They were then prone to opportunistic infections. The clinical team wanted to understand what type of infections were affecting the patients, and they wanted to understand what pathogens. But when we look at MedDRA preferred term level, there were multiple pathogens and sites in combination at the preferred term level. And the team wanted to be more general than this. They wanted to just count very simply, for example, how many bacterial infections or how many infections with a specific bacteria, regardless of the body site. And this wasn't available at the preferred term level, but the company that I was with at the time only stored in their clinical trial database the preferred term. So, and the SOC and the verbatim term. So in order to do this, we had to do some programming to use the HLT to capture the pathogen, or even the HLGT level, where you would find bacterial infections, viral infections, fungal infections, and to count at that level. So knowing how your database is structured, whether it's a clinical trial or your own internal database, can let you know what other work might need to be done ahead of time when you're planning your retrieval strategy. I've already explained about data conversion and how data conversion can impact where the terms are placed within your version of MedDRA, depending on how you converted from legacy terminologies. Similarly, being aware of your coding practices over time. If you find that your own internal coding conventions have changed, you'll have older reports coded differently from the terms which are received today. So if you think about that, unless you go back and do what I would call cleanup and changing the coding of these older reports, unless you do that, you will have a mismatch in your coding practices and where the terms are placed. So be aware of this. It's good practice if you do change coding conventions to go back and change the older reports to match your latest convention. Be aware of any limitations and restrictions, particularly inability to view secondary SOCs. The secondary SOCs are there for supplementary analysis. You might want to do a focus search, and that's something I'm going to explain. But if your organization's IT infrastructure doesn't allow this, you need to find another way of doing it or organize some additional programming. And we have some data analysis tools within the MedDRA browser that can be used if you don't have that ability within your system. So bear that in mind. The last point here to be aware of is that term selection principles can impact the way your data will appear in your database. If you code more than one term, now if we think of the example of a diagnosis reported with signs and symptoms, if you code that diagnosis and all the signs and symptoms separately, you will have more counts for that patient in your database. Whereas if you only code the diagnosis term, that will reduce the number of counts in your database when you do your analysis, your retrieval. Now we come to think about the impact of MedDRA characteristics. Firstly, the grouping terms. The HLGTs and HLTs provide clinically relevant groupings. Here we see an example of the HLTs capturing cardiac arrhythmias. We see there's one HLGT for cardiac arrhythmias, and underneath that there are HLTs grouping together conditions that are specific types of arrhythmia, such as cardiac conduction disorders or supraventricular arrhythmias. The entry that you see there, rate and rhythm disorders, NEC, means not elsewhere classified. So if you're not familiar with this acronym, within MedDRA, it captures the miscellaneous types of arrhythmia which don't fit into other HLT groupings. So we see there that these groupings could be used to summarize our data. We could count how many patients have got a cardiac arrhythmia using the terms coded to terms within that HLGT, or even if I wanted to count how many supraventricular arrhythmias, I'd include all the preferred terms and LLTs, capturing all the patients coded to any of those LLTs under that HLT of supraventricular arrhythmias. So you see how the groupings can be useful for counting, similarly to the example I gave you where my team I was working with wanted to count the infections, how many patients had a bacterial infection versus a viral infection, and that information was available in the MedDRA hierarchy at the HLGT level. But if you think about it, we're only going to count the patients that have a diagnosis and reported and coded into those sections. We wouldn't count the patients who maybe have symptoms of an arrhythmia because those symptoms would be coded elsewhere to MedDRA terms. The other difficulty with using, or the other caveat I should say, when using these grouping terms at the HLT and HLGT is that sometimes you'll find that the terms within that HLT, they may not all be relevant to what you're trying to count. If we look at the example, vascular tests not elsewhere classified, this is going to capture abnormal results in blood pressure, for example, which is both increased and decreased. So if, depending on what you're looking to count, make sure that all the preferred terms are actually relevant. And then the flip side of that is that you may want to group patients with different conditions, and those conditions are in different HLTs or HLGTs. The example we see here are severe cutaneous reactions, and we have bullous conditions, which would include Stevens-Johnson syndrome, separate from exfoliative conditions like dermatitis exfoliative. So you need to think creatively, even when you're using the standardized levels, the hierarchy of MedDRA, to make sure that the PTs within those sections capture everything that you're trying to count. And it may be that you do need to combine HLTs, or that it may be that this is not a good approach for you. So this is just one of the features of MedDRA, but it's not ideal for the reasons I've just described. Multi-axiality is another feature of MedDRA which can help you with your analysis. But remember that the primary SOC allocation rules will affect the way the data are distributed across the terminology. I've already mentioned that we always code to the primary SOC. So when you see your patients and you have a line listing, cumulative report, you're going to see that some of the patients will fall into one SOC, depending on if their event is reported with a symptom, which might affect a different body site. That will be set, those will appear separately from patients who have a diagnosis, so the underlying cause, where they will be coded into the relevant diagnosis term, and that will be in a different SOC. So this is something you need to be aware of. We can use the multi-axial links to combine when we do a query. We can combine the symptoms with the diagnoses by using the multi-axial links. But remember, there are 3 system organ classes in MedDRA which don't have multi-axial links. This is all information that we cover in some of our earlier webinars around the basics of MedDRA. What is MedDRA? How is it used? So if you're not familiar with these features of MedDRA, you'll be welcome to come on one of those other webinars. But for now, as a reminder, just be aware that there are multi-axial links that can be used to group patients with a diagnosis together with patients who may not yet have a diagnosis and may just have symptoms. But the SOCs of investigations, surgical and medical procedures, and social circumstances don't have any multi-axial links. So if you're doing a search here, we see for a renal abnormality, you would need to combine the patients with diagnoses from that SOC of renal and urinary disorders. That would include patients who have a diagnosis, also the signs and symptoms, which would have a secondary link into this SOC. But you'd also need to manually look for patients with relevant investigation abnormalities, procedures, or social circumstances. And we see some examples there, like artificial kidney device user, which is a social circumstance, or renal transplant, which would be a procedure. So bear that in mind when you're thinking of searching. You need to be comprehensive and search widely using the multi-axial links for symptoms as well as the investigations, procedures, and social circumstances. The main presentation is always by primary SOC, and secondary SOCs are used for alternate views and presentation of the data. I think I'll pause there just for a moment to see if we have any questions, because I'm aware that we've covered a lot of basic information already, and I don't want to go on too far.
Currently no questions, Jane. Thank you very much.
Thank you, Leander. So now let's think again about what level of MedDRA might be useful for showing a pattern in the data. There's a saying where they say, sometimes you can't see the wood for the trees. If you're confused about something or you feel you're surrounded by information, it comes from the idea that if I was lost in a forest, I can't see where I'm going because all around me are trees, and I can't, if I'm lost, how do I know where to go? And preferred terms are a bit like that, that they're so detailed. We see here the SOC of investigations, and we're looking at the results for a drug arm versus a placebo arm. We can see at a glance that there are more events or a higher proportion of events under the drug arm versus the placebo. But can we see a pattern? So by looking down, can I see a clear pattern there? Initially, it looks like liver problems, but not exclusively. There are some other results there, like white blood cell count decreased. So I can't see a clear pattern. And imagine if this was multiplied, that you had pages and pages of results and reports there, all coded to the preferred terms. There you see some more on the second slide. We see again that the liver again, but also monocytes, and it's hard to see a clear pattern. And just as I say, if you're lost in the forest, you can't see the wood for the trees. It's almost like if you could fly above, if you could rise up and fly above that forest, like when you're in an aeroplane, it's much easier to see the outline of the forest. And it is the same with the MedDRA terms. If we go up a level, so if I would say, go up again to the HLT level, we get a more general view and we get a pattern. So we see that it is in fact liver function analyses, which seem to have the majority of the events coded into that HLT, but also there are some other digestive enzymes, white blood cell count analyses, as we saw when we were looking at the data. So think about this, think about using the higher levels of MedDRA to summarize your data. And again, this is the same example I gave you where I was working with a team wanting to summarize the infections at the HLT or HLGT level. You can do that in many scenarios depending on your area of interest. So now we move on to the general principles of the data retrieval and presentation document that cover MedDRA versioning. So as we're all aware, MedDRA is updated twice a year. On the 1st of March, we will get 29.0 this year. And on the 1st of September, we'll have the 29.1. And this is the same every year. March is 0.0 release. That includes changes to all levels of the hierarchy, whereas in September, it will just be changes to the LLT and PT. The version of MedDRA that you use for your data retrieval and presentation should be documented, and you should also match the version of MedDRA used for coding to the version of MedDRA you use for your query. So that's something to be aware of, the last bullet point here on the slide. Because if you design a retrieval strategy based on today's version of MedDRA and you select preferred terms that are of interest, but your data were coded maybe over the last 2 or 3 years, the data may have been coded to older versions of MedDRA, and then you'll have a mismatch. You won't find the cases because they would be coded elsewhere. So you may miss cases during retrieval if you use a different version of MedDRA for your query that's different from the version used for coding those data. The bullet point there in the middle explains that we do have resources to help you understanding your MedDRA versioning. We do a webinar and a document called What's New with each new release of MedDRA. We have MedDRA best practices document that tells you a lot about versioning, especially clinical trials versioning. There's a version report which is distributed with the new MedDRA release every 6 months. And we also have an interactive tool called the MedDRA version analysis tool. This is available both as a standalone tool and within the MedDRA browser. So when I go to the website, I can show you some of these documents and the tools where you can find them. So just pointing out how the MedDRA versioning can affect your data. If we look at an example here, going back to MedDRA version 22.1, there were 2 preferred terms, fractured ischium and pelvic fracture. And so we would see 15 patients were coded to LLTs underneath the preferred term of fractured ischium and 5 under pelvic fracture. But in the next release, version 23, fractured ischium was no longer a PT. It was demoted under the PT of pelvic fracture. That term became an LLT. So we would then see 20 patients coded under the PT of pelvic fracture because the additional LLT has taken those 15 patients underneath it. So this might explain year on year, you'll see changes to your data based on MedDRA versioning. So it's a good idea to familiarize yourself with the changes that have occurred with each release every 6 months. Another example shows how the moving of a preferred term from one SOC to a different SOC can again change the way your data appear in your listings. vascular cognitive impairment was under psychiatric disorders, but in version 23 it was moved under the SOC of nervous system disorders. So you see there that the 20 patients that were under psychiatric will now appear under nervous system disorders. And this is going on with every release of MedDRA, not just in the older versions like the one I'm showing you here. So familiarize yourself with what has changed. You can run reports as well as seeing the report that we distribute ready for you, showing you all of the changes to terms with each new release. This is the MedDRA version analysis tool that I mentioned. The standalone version has a URL. I show you there, that's the web-based version. It's a free tool. It is used by available to all our users as part of their subscription, and it has three main features. It has a version report generator that produces an exportable report comparing any two versions of MedDRA, and I can show I can ask the tool how the differences between the two versions of MedDRA, any two versions, and I can show you how to do this. Data impact report does the same, but this allows you to import the terms that you used for coding. So if you have a data set, you can import the coded terms, and the tool will show you the changes to your coding impacted by the new release of MedDRA. And the third feature is where you can look at the history of a term and how that term may have changed over the whole 25 years now of MedDRA, over 25 years. We can see how a preferred term may have moved to a different SOC, or an LLT may have been made non-current, for example, the history of an individual term. So these are the features of the MedDRA version analysis tool that, and as I say, it's available on the web and in the browser. It's available in multiple languages, the interface and the report. You can run reports that include the supplemental changes to MedDRA. Supplemental changes are changes which have been approved, but they're waiting for release in the next version. So now we're waiting for the 1st of March for our new release. So there will be terms waiting that have been approved. That's what we call supplemental terms. And you can see those within the MVAT tool if you run it within MVAT, and also in the browser, the legacy web-based browser can show you those supplemental changes as well. The MVAT tool gives you the option to run reports on secondary SOC changes as well as the primary SOC, and that we do have webinars explaining how to use MVAT in more detail than we're able to show you today. And there's a link there to the training materials where you can watch those webinars. So let's just pause here. If we have any questions, Leandra, I'll take them. And I'm going to go to the website now just to point out the documents and the tools that we have been talking about.
Thank you, Jane. Currently no questions, but I'll let you know if there are any. Thank you.
Okay. So let's go to the website then. I find these things get harder and harder every time I do it. There we go. Just proving I'm human here and use the browser. So this is the MedDRA website, the home page. The browser can be accessed in several ways. So you can access the MedDRA browser from the top right-hand side. You see there's a quick link, WBB, top right-hand side. This browser is a version that I could call the legacy browser. So let me just, there we go. This is our long-standing web-based browser. We have brought out an updated version of this, but I've gone to this one because I want to show you the supplemental terms. So you can view the supplemental terms by changing at the top, release or supplemental view. Change it to supplemental. You see that the screen has turned pink, and this is where you'll find terms indicated that they are new or supplemental terms. So I'm just going to put in the word drug, because usually we can find somewhere there will be something and medication errors, or there are some there. I knew there would be some. You see the green dotted line around these terms: biodegradable drug insertion, biodegradable ocular drug insertion or migration, for example. So these are new concepts, new terms that have been added to MedDRA, but they're not active yet. They're not in, they haven't been released. They're waiting for version 29.0 on the 1st of March. So that's there to show you there in the browser. So that's the browser. Let me go back to the website. There also, you can access the browser under the tab How to Use, Tools, and on the right hand side, so we have a whole page devoted to browsers, you see, one of the cogs. And also we have quick links on the right hand side, opening the web-based browser or opening the new web-based browser. So these are the two links for the browsers. The new web-based browser looks slightly different. It's a larger interface, more clear, because we've put the features that you see on the legacy, we've put them under the settings, and we've used smaller icons which you add to your navigation bar by customizing the screen. So everything is exactly the same. All the features are there. I've customized my screen to show all the same features that are on the other one, but these have now got icons instead of full buttons, so you hover for the tooltip. So that's just to show you there the second browser, the new browser, and Leander's put the demo credentials in the chat for you if you want to access the browser now or after the webinar to consolidate your learning. You can do that with the credentials she's given you. And we see here on the tools page, we have a link to MVAT. So MVAT is the, there Leander's put it in. Here we see the versioning page. It tells you about the MVAT tool. This is the home screen for the MVAT tool. And on the right-hand side, there's a link opening MVAT. And there we see we can open the tool, and here this is what I was telling you. I can choose any two versions of MedDRA. I can say show me the difference between version 27 and 28.1, for example. If I wish to limit my search to individual socks or groups of socks, I can do that. And then the button at the bottom, grey button, I can run a version report. So this will give me the report. It will appear in my downloads, and it will list all the individual changes, each type of change, on a separate tab of the Excel report. Just while it's doing that, if you cast your eye over to the right-hand side, you see there the other options. These are data impact report that I explained. That's when you import your own data and you run the analysis on your own data, showing the changes to MedDRA which impact your coding. Here's a summary of the changes between the two versions. So I asked, remember, from version 27 to 28.1, I can see that there were 785 new preferred terms, for example. I can view the details on the screen, or what is better is, as I mentioned, to click the button export, and it will instantly take it into my downloads. So there I see it's available already in Excel. Here it is. The top tab of the book gives the summary that we've just seen on the screen. There's 785 PTs, for example, and each of the tabs along the bottom allows us to see the actual changes. These are the new PTs, the 785 new PTs, showing us the name of the PT and the location, the placement in the hierarchy. And we can do that for any of the changes. I can look at any terms that have been made non-current or may have been were originally non-current and they've now been made current again. So you can spend time on that. And as I say, there's a whole webinar devoted to that. So come along to one of our other webinars, or you can practice offline. So that's the MVAT, and it's also available now as a feature within the browser, the new browser. You don't need to go to the standalone tool. So now thinking about the use of MedDRA in data retrieval, presentation and analysis. As I've already mentioned, your first level overview is always by primary SOC. This is the standard approach, and you should use the internationally agreed order of SOCs when applicable. If you're not familiar with that order, you can find it in the EU Summary of Product Characteristics Guideline or in the MedDRA Introductory Guide or ASCII files. Another thing to bear in mind, we've already mentioned considering the use of HLTs or HLGTs to summarize particularly a large data set, and we've looked at two examples of that, both with the table on the screen and my example I gave you. Think also about tables and graphs. Sometimes a picture is worth 1,000 words, they say, don't they? So I've got a slide in the next slide shows you how a graph or table, a graph can be used to summarize. We can see at a glance here that there's a problem with psychiatric disorders, nervous system disorders, gastrointestinal and general disorders. But going back to the idea of having that primary SOC overview, it gives you a broad overview. The preferred terms are only displayed once, but the limitation, as we've already mentioned this, is it may appear as if your data are grouped incompletely. Because you've got symptoms under one SOC, you've got diagnosis under another SOC, investigations are somewhere else, procedures, and this is due to the SOC allocation rules of MedDRA, and also it can be very long. If you have a large data set, it can be a very long output. So this basically is your starting point. You always start with an overview by primary SOC, and from there you can see a pattern, and you can decide where you think that there's a need. You can do more focused analysis. You can summarize by HLTs and HLGTs if that helps you see a pattern, and then you can apply a query or use an SMQ or do multi-axial searches, any of the features of MedDRA to further explore a trend that you see in your data when you've done this primary SOC overview. This is what a listing might look like of a primary SOC overview. We're seeing nervous system disorders here, a particular section of mental impairment, movement disorders, and neurological disorders not elsewhere classified. And it's giving us a count of the patients who have an event coded to one of the LLTs under that preferred term. So we code to the LLTs and they fall under the PT. And typically, because the PTs are unique, whereas the LLT level has a lot of synonyms, we present data at the PT level under the SOC with the levels of hierarchy that you choose to present. So here's a question for you now, back to our polling. You can scan the QR code. If the safety data are to be presented in tables or other format, should you choose the primary SOC based on product specifics or follow the predetermined MedDRA hierarchy when you are presenting your data in tables or other formats? Which approach should you take? Remember, you've got the credentials there. Leander's put the credentials in the chat for the polling, and it's on the top of the screen there. Polev.com is all you type in, and then when you get the next screen, you enter my name.
Jane, would you mind just clicking on the QR code to make it a little bigger? It makes it easier for opening. Thank you.
Okay, so let's see how you're doing. I see any more of you voting? Still going up? I'll just wait a few more seconds till it levels. So let's see how you're doing. Well, mostly you're thinking that you would choose the primary SOC based on product specifics. But remember what we said. Remember the slide going back. Do not alter MedDRA. You must always, when you present, you must follow the predetermined MedDRA hierarchy. Let me go back to the slide to just show you, remind you of that. Your overview is by primary SOC. You always present by primary SOC. You use the internationally agreed order of SOCs when applicable. So when you're doing your first primary analysis, you must use the MedDRA predetermined hierarchy in order to present your data in tables or other formats. So if something was not clear there, I do apologize, and let me know and I'll go over it again. So we've done our primary overview. We can see a pattern, and we're looking now to do a focused search. This is when you can use the secondary SOC assignments for your analysis, not by changing the SOC coded for the data coding, but by doing an analysis by activating the multi-axial links. Your database may need programming if you don't have it as a standard within your IT system, but the benefits of being able to use secondary SOC assignments is that it gives us a more comprehensive view. We're able to combine patients with a diagnosis together with patients who may have reported symptoms which have been coded to a different SOC. So by activating the secondary SOC allocation links for those symptoms, we can combine them with the patients with the underlying diagnosis. The limitations, though, is that if you're displaying those patients by primary and secondary SOC, it could lead to double counting. So make sure you're not counting those patients twice. We've already seen how the features of MedDRA, the HLT and HLGT, could be used to further investigate by seeing a clearer pattern. And then next week, we're going to talk about the standardized MedDRA queries and customizing searches, i.e. modifying an SMQ. But today, later on, I'm going to show you how you build what we call an ad hoc query. So these are your focus searches. An example of where I might want to do a focus search is I may have a question that crosses my mind when I'm looking at my primary SOC allocation listing, or it may be a question from a regulatory authority. How many cases of autoimmune disease are there in my patient group in my data set? Here we're seeing a small data set with patients coded to the primary SOC allocation. Remember, you would always present your data by primary SOC allocation for your overall listing. And here we're seeing these events, preferred terms. How do I know which of these are autoimmune? Evans syndrome. Well, autoimmune neutropenia has got the word autoimmune in the name of the PT, so that one's fairly straightforward. Likewise, autoimmune myocarditis. But what about these others? Without knowing Evans syndrome off the top of my head, I would have to go and research it, find out, is that autoimmune or not? But maybe MedDRA can help us with this question. A second slide, birdshot chorioretinopathy, for example, autoimmune uveitis. I would need to check each of these, and there are various ways I can do it to find out which of these are autoimmune. There's the third slide there. So I've got 3 slides, a very small data set, as I mentioned. How can I answer that question? Well, have a think for yourself. How would you go about that? And to show you, I'm going to go to the browser and I'm going to show you some of the options we could use. So this is the new browser. I showed you the legacy browser before. I've now switched over to the new version of the browser, the web-based browser. So I could call them up. I could type them in and look up Evans syndrome, for example, one that I remember. Evans syndrome, here's the LLT, there's the PT. If I open the hierarchy, I can see that it is in 2 HLGTs. It's in blood and lymphatic disorders system as well as immune system disorders. And look at the HLT. The HLT is autoimmune disorders. So I could search one by one individually. Another way of doing it, I can put my cursor on the PT name, open details and occurrences, and that information automatically appears there on the right-hand side. Evans syndrome does have a link into the HLGT of autoimmune disorders. So I can do that. I could do that with all of the terms. Birdshot, let's just look up birdshot. Birdshot chorioretinopathy was the term. There it is. I can do the same again. Right hand side, right hand click. It'll do it now because I did it before, and it shows me there that also has an autoimmune link. But that's going to be very time consuming, having to do that one by one by one. So there's various ways we can do it. We can do a search and then export the results of the search, but it would then show me all the information on the right-hand side. It would put it in Excel, but that's still going to be very time consuming exporting the results. Another thing we could do is to say, I'm going to put them in a basket. So I could use the research bin, show my research bin. My research bin is empty. This is a bit like online shopping. So I'm going to close that for the minute, put that into the research bin, add it to the research bin. There it is, birdshot chorioretinopathy. I could do that with all of the individual terms in the list. And then when I've got a complete set, I'm just doing it now to show you quickly, I could export it. And when I see here, it would tell me what the SOC was, whether this was the primary or secondary SOC for that birdshot chorioretinopathy. So that's not really very useful either. So the import settings, export settings, it tells me there the settings of the what we've exported there, but this is what we'd be looking at. So that's not very helpful. The better way to do it, I'm just going to close these Excels because I've got too many of them open. The better way to do it would be to take and I'm going to do a demo of this, take the data set and use one of the tools that allows us to do a hierarchy analysis. So I'm going to click on the tools icon. Here I can see the versions of MedDRA. I'm going to do the hierarchy analysis. This is the MVAT report. As I showed you, it's in the browser now. I also have the data impact report separately, and I have the hierarchy analysis. So if I go to the hierarchy analysis feature, I can click, I don't want version 29, let's do version 28 because that's the version for our training materials. I don't need to see this. I need to see the secondary SOCs because I want to capture every patient who has a secondary SOC of the immune system disorders, in particular the HLGT of autoimmune disorders. So let's import this data set as a file. So I've got it all in an Excel file and I'll show you that shortly, but let's go for now. Let's find it on my computer, MSSO work. MSSO training, and I've got it in I had it open before the session, but it's obviously closed. Secondary SOC analysis exercise. I find that spreadsheet, I import the spreadsheet, and it's done it already. It did it in that time instantly. It's in my downloads, hierarchy analysis. If I open the file, I'll see here. Now let me just, because I've done that quite quickly, so let me just explain to you all. So what I've done, I'm going to go back to the slides to explain it again. I've taken the data that I had shown on these 3 slides, the 3 slides I covered. I've taken those data and I've imported them into the MedDRA browser. So I'm not going to do that one because in the interest of time, I've gone to the MedDRA browser. Here are the links for the MedDRA browsers. Just you've got them in the slides that Leander sent out for you. And we've talked about the MedDRA browsers. And here are my data set. Here are the terms in my data set. And we can see that they're all in different SOCs. That was our starting point. We could see they're all in different SOCs. So I went to the browser and I showed you how we can do a search and we can export the terms one by one, but that's going to be very time consuming. So then the other option is to export the search results, and I could use the research bin for that. And that's not very helpful either because it's, again, too time consuming. Putting every term in the bin one by one, just like online shopping. So what we've done is, and that's why I've skipped over the other two options quickly because they're not ideal. This is the option you want if you ever need to do this. What we've done is we've uploaded the terms from a spreadsheet format and we've exported them, showing both the primary and secondary SOC hierarchies. There's no need for you to do any programming in your own database. If you use our browser, you can use our tool. And what I'm showing you now are the results of that hierarchy analysis feature. And this is what I have. So you have a record of it in the slides, and I'll go back. This is what we have. We've done it live in the browser. So let me show you the best way to understand it. The best way to understand this is to take the top row. So I'm going to delete the top two. I don't need that heading anymore. It gives me the date, but for today's purpose, I don't need that. So I'm going to delete those rows. For simplicity, I'm now going to take the top row and apply a filter. So data and auto filter. So now you can see that I've got a drop down arrow. I've got a filter on the results because I'm seeing every preferred term multiple times because it's in multiple SOCs. So if I go to the HLGT, I do a drop down and I can now focus in on the HLGT name, autoimmune disorders. I'm asking it to only show me those preferred terms that have a link into the autoimmune disorders SOC, HLGT, in the immune system disorder SOC. And there they are. And now we can see that there's only one term that is primary to the immune system disorder SOC and the autoimmune disorders HLGT, and that's because the term is autoimmune disorder. It doesn't have a body site specified within the term. All the others have a body site or a specific disease within the PT, and they're all placed according to site of manifestation. As we know that's the rule in MedDRA. Terms are placed by site of manifestation, except for congenital disorders, neoplasms, and infections. So that's why this is the easiest way to capture all the terms that are autoimmune, because autoimmune would not be a site of manifestation. So therefore, in most cases, it will be a secondary SOC. And that's exactly what we're seeing here in our results. So we've been able to answer the question, go back to my slide, how many terms in my primary listing were autoimmune? We can do that by using the browser and running a hierarchy analysis to see that there are 11 conditions that would be considered autoimmune based on their secondary SOC placement. And this is what we would see. If we use the secondary SOC as the grouping term, this is how we would see the results. Now I'm going to pause there because I want to make sure if it's really not clear to you, then let me know and I'll go through it again.
Thanks, Jane. We did have a question that said, could you explain how to obtain this spreadsheet? And I know it's a demo spreadsheet, so that might have caused a little confusion, but could you explain how to obtain the spreadsheet?
Yes, so the spreadsheet is one that I have it here because I do it for demonstration, as Leander says, secondary SOC analysis exercise. So we don't send this out to you because it's just for demonstration purposes. But I can open it and show you. All it is, there's a format which has the row ID, the term, and the code. So when we were in the browser, it showed us the format that was required, and that's what I followed here in creating this spreadsheet. You don't need both the term and the code. You only need one or other, but I've shown it here with both just for completeness. And all you're seeing here is the same list of MedDRA preferred terms that I showed you over those 3 slides. So this is the spreadsheet. This is the format you need, and this would be your data, either the code or the term. If you don't have both, you don't need both. And I'll go back to the browser. There's the format on the browser. Do you see that on the main page of the browser? Let's get rid of this. There we go. So we can see there's the row ID, the LLT or PT, and the LLT or PT code. Only one of them. You don't need both. It tells you at the top you don't need both. You do need the headings, but the column can be empty, and there it tells you all about it there, how to create the spreadsheet yourself. Any other questions or comments, Leander? Anybody completely confused?
No, we had a thumbs up on that one, so that explanation helped. Thank you, Jane. But no, at the moment, there's no other questions. Thank you.
Good. I appreciate that. Thank you. I'm aware that it is quite a difficult topic, that one, showing how you can do it. So you do it within the browser. Let me just, before we move on, I'll just pause there in case anybody, do tell me if it's not clear, please do tell me. So I'm going to go now to the legacy browser, just to show you in the legacy browser. I'm going to take it back to the default setting. No longer need to see the supplemental terms. So now this is the release view of MedDRA. Here you've got a button. Let me see if I can highlight that. Here at the top, I can just say here, oh, that was a bit of a thick drawing, wasn't it? Stop drawing, fade out the drawings. There we go. Right, let me try again. Up there, you got the idea. SMQ analysis and hierarchy analysis. You see where your eyes need to be. Top right-hand side of the screen, SMQ analysis, hierarchy analysis. These are the 2 buttons. This week, we're using hierarchy analysis. Next week, we're going to use SMQ analysis to show you SMQs. So the hierarchy analysis, let me click it. You see exactly the same again. It's telling me what version of MedDRA. This is in version 28. I'll go back to. Again, next, I can do exactly the same again. There's the format. Choose my file. Let's hope it doesn't take, yeah, that's taken me to the right place now. SMQ, secondary SOC analysis exercise, there it is. Find the file wherever you've stored it, and it's done it immediately again. It's popped up immediately, and there's the results again, exactly the same from the other browser. So you can use either browser, it works exactly the same. Again, you would put a filter on. Let's enable editing, shade the top line, data, filter, and then I know that the HLGT I'm interested in is autoimmune disorders. So there I go again with it, autoimmune disorders, filtering my results, and I get the same result, the 11 terms there. Only one of them is primary to the immune system disorder, SOC, autoimmune disorders, HLGT. Hopefully that helps for anyone who's more familiar with the legacy browser. So this is your last chance for questions on that topic until the end. We'll move on now to a different topic completely. This is where you've done your primary SOC overview, you've looked at that, you see there, you think there's a trend, you want to explore what you think you see in the data, and you want to build a query looking for patients with a particular medical condition that you're interested in. You think you see a trend and you want to build a query. So let's start with that. What is a query? Well, let's focus on the right-hand side here where it says query. A query is a list of preferred terms. Now on the screen it says SMQ because that's a standardized MedDRA query, but it doesn't have to be. It could be a query that we've built ourselves. Maybe there isn't a standardized MedDRA query for the topic that we're interested in, and so we need to build our own query. And this is why we do this webinar and why we teach you. All it is a list of preferred terms, and those preferred terms break down into LLTs, and that's what we're seeing there on that piece of paper. It's like a shopping list. So the preferred term is the level that I use for building the query. The preferred terms break down into LLTs sitting underneath them. And I take my list and they match against the cases. So the cases are in either a clinical trial database or a safety database. That's what we see on the left-hand side. Within those databases, there are cases coded to LLTs, and I come along with my list, my query, and I'm looking for a match between the preferred term, which breaks down into LLTs, matching against the case, and the patient's events have been coded to LLTs. Where there's a match, there's a hit, and that patient would be retrieved. Just because a patient has a particular symptom potentially doesn't mean they necessarily have the condition that I'm interested in, but they could have. So I would need to do some manual review of those patients. When I retrieve them, I can't assume, especially when I may be searching for symptoms, which could be indicative of multiple different diseases, I can't assume that the patient with that particular symptom necessarily has the condition I'm interested in, but he may have. If I look for patients with a diagnosis of the condition of interest, then I can be more confident that they do have the condition, but just be aware, if you're looking for symptoms, they may not have, it may be suggestive of a different disease. So that's what a query is. What is the first thing you do when building a query? This is a poll for you now. We haven't covered this explicitly so far, but what do you think would be the first thing you do when you build a query? I'll open this again for you so you can see. You can scan it. What's the first thing you do when you build a query? Would you open the MedDRA browser and select the PTs? Open the MedDRA browser and select relevant LLTs, get a clear understanding of the medical condition of interest, and define inclusion or exclusion criteria. What do you think is what would you do first? So I've reviewed my data. I think that there's a trend, and I want to look for patients with this condition. What would I do first? I'm going to let you think this through because I've got this on a slide, and I'm asking you the question before I've shown you the slide because I want you to think it through for yourself. What would you do first? See whether you agree with. Let's have a look at where you are. Oh, very good. The first thing is you need to get a clear understanding of the medical condition of interest. Absolutely. Well done. Well done. I'm happy with that. Well done. The first thing you do is you define the condition. You need to be clear, what is it we're looking at? We know that MedDRA has in the region of 90,000 LLTs, 30,000 preferred terms. So when we go into MedDRA, we're going to see preferred terms of all kinds, and it's very easy to get sidetracked when building. So know initially, know upfront, what is the condition we're looking for? And are we looking for every type of that condition? Or maybe it's a subset of the condition. Maybe there are inclusion-exclusion criteria. Maybe there are protocols for diagnosing that we want to use, some lab results, for example, which would help us to know how to define the patients who have this condition. Well done. Next, then we come to build our query. We use the grouping terms where applicable, and I'm going to show you this in the browser. So what I'm saying is it may be that we want to include a whole set of HLTs or HLGTs, but based on the MedDRA hierarchy, and we can search for a whole set. Let's use those grouping terms to our advantage if we can. Remember the non-multi-axial SOCs. So these are investigations, procedures, and social circumstances. Also, the other SOCs, like it might be relevant if we were looking for patients potentially who have a bleeding disorder or a clotting disorder, we may be interested to look in the injuries, poisoning and procedural complications SOC, because we'd be wanting to look for patients who have bruises or specific bleeding complications, for example, injury terms. So there may be some terms within the other SOCs that we're interested in. It may relate to pregnancy. Also, remember, we've got the general disorders and administration site conditions SOC. So that's what I mean by the other or support SOCs. When you find a term that you think represents the condition of interest, you want to look at the neighbours of the term, including secondary locations. And you avoid using LLTs. We just have a little note there that in the infections and infestations, there may be some specificity at the LLT level, but generally the other SOCs don't have any specificity at the LLT level that would be relevant. The PT is usually adequate. So we build our query at the PT level. The reason we say to avoid LLTs is that there are so many synonyms at the LLT level. So stick to the PT level. So I'm looking to build a list of preferred terms. Remember, going back now to where we were, a list of preferred terms. I'm going to show you that picture again. I'm wanting to build the list of preferred terms that represents the patients who have the condition I'm interested in. So this might be patients with a diagnosis of the condition. It might be symptoms of the condition. It could be lab results. It could be procedures. It could be anything that could be presented and coded when the patient has the condition I'm interested in. So I'm going to build my query. When it's built, I'm going to store it for future use. But remember, you need to check it every 6 months because MedDRA comes out every 6 months, and there may be new MedDRA preferred terms added which are relevant to your search. And again, what we say is match the version of MedDRA used for coding to the version of MedDRA that you use for building your query. Don't look for preferred terms that weren't available when the data were coded, but equally keep your query up to date by adding the newly added preferred terms if they're relevant, and that's if your data are being coded currently to the latest release of MedDRA. So now a question for you again. What aspects must be considered when building a query? Are you considering the quality of your source data, your internal MedDRA version update processes, the MedDRA structure, or your organization-specific coding conventions and data characteristics? Which of these? And you can select as many as you want to. What are you going to consider when building a query? Okay, let's see. I've given you a bit of time there. You can carry on voting. The quality of source data, yes, that's certainly important. You do need to consider that, because if your data are not coded consistently and according to standardized conventions accurately, if they're poorly reported cases, the quality of the received report is poor, then you're not going to have very clear output. So you need to bear this in mind. Think about how would those patients have been coded. Next, do you need to consider the internal MedDRA version update processes? Yes, absolutely you do, because you need to think, I'm querying some data that I've received. Have those data been updated to the latest version of MedDRA? Maybe you have a policy to update your clinical trials every 6 months or your safety database. You probably do, because the regulators require serious adverse events to be sent in with the latest version or maybe the previous in majority of cases. So you likely do update your safety database. So you need to make sure that you understand the version of MedDRA used for coding the cases, and you need to match the version you use for building your query to the version used for coding. MedDRA structure. This one is less much. I would say this is the one that is not so much of a consideration. I would build my query using PTs, and beyond that, I don't need to pay so much attention to MedDRA structure. Just knowing that you need to know that you need to understand the MedDRA structure. Yes, less important, I'd say, than version updates. Or your last one is your organization coding conventions. You do need to know how your data have been coded, so you know which preferred terms we need to look for. MedDRA structure, we need to know that MedDRA has the investigations, the procedures, the social circumstances, those non-multi-axial SOCs, but generally we build at the PT level. So that's probably less of my consideration there. Well done. So here's one for you to click on. The preferred terms in the query may relate to which types of data? Oh, it is working. I'm just checking, was it working? It is working. Could it include histopathology if they are in MedDRA, toxicology if those terms are in MedDRA, physical findings, types of death? Well, you've got so many votes here, it's hard to read what's underneath it. But I'm going to make it easy. All of these types of data could be included as preferred terms in our search. If there are other terms in MedDRA in any of these categories, depending upon what we're looking for, any of these could be included in our query. So we need to think about the whole breadth, the whole expanse of MedDRA scope when we're building our query. What level of MedDRA hierarchy is generally used for building a query? Now, I've definitely told you this. So, yes, PT, the PT. It's going to get bigger. The more of you vote, the bigger it's going to get. PT terms. PT terms. Good. Very good. We use the PT generally for building our query.
Jane, we had a question on that.
Yeah.
We had somebody who became a little confused because previously we talked about applying HLGTs.
Yes.
But now we're talking about building the queries on PT.
I'll demonstrate that. So I'll demonstrate that. I'll explain the difference. So I would use the HLT or HLGT as a grouping to find the PTs I'm interested in. So I'll show you what it'll make much more sense when we see it live. So we're fine here. We would only use LLTs if we think that it's infections, but generally I'd say let's focus on PTs for building our queries. We're going to build our query with PTs. Here's a browser demo credentials. Leander's already given it to you, but you can, if you haven't got the browser open, you might want to do so for this next section and follow along. And if you get stuck, Leander can tell you again. So let me go. We're going to do an example together now for cardiac arrhythmias. So I'm interested in cardiac arrhythmias. So and I'm going to show you in the browser how we do this. Okay, so you've got it detailed on the slide. Let's go back to the browser. Let's close this. I'm in the tools, remember, so I'm going to close that. So I'm going to show my bin. I'm going to use the bin again. Let's do this. Show the research bin. I'm going to clear the bin. Remove the selected. So now my bin is empty. So I'm just going to close that for now. So I know it's empty. Let's check it's empty. Show the research bin. Yes, it's empty. So I'm now going to build a query for arrhythmias. Now, what did I mean when I said you may want to think about the HLTs and HLGTs? It's a way of finding the preferred terms of interest. So I can look down, cardiac disorders, SOC. I've opened the cardiac disorders. Let me make this slightly bigger for you. There we are. So I've opened cardiac disorders and I can see immediately there's a whole HLGT of cardiac arrhythmias. And that's what I mean by using them. So I can select that and I've got two options. I can do a right-hand click and I can add it to my research bin. And I'll do that. And look what's happened. It's put an HLGT in my basket, but I don't really want that name because what I want to do is I want to export my list and give it to one of my, perhaps I've got a programmer, statistical programmer who can run that in a query tool against the data. Now, my data are coded at the LLT and the PT, and that's the level, the PT or the LLT, one of those levels is where I want to match. So what I want to do is I want to get a list of PTs in my basket, not an HLGT, because when I run the query, I want to match at a consistent level. So I'm going to remove that. I'll show you what I mean. When I do a right-hand click, I can add selected levels to my bin. And that's the one I'm going to choose. So I have the option. I don't want to add the HLGT, the HLT. I don't even want the LLTs. I just want the PTs. And when I do that, I get the whole list of all the preferred terms within the HLGT in my basket. So that's very quick. Really, I was too quick that. What I should have done, I should look through these, take the time to look through all of these and check, do I actually want all of these in there? It may be that I want to be more specific, but do I want all arrhythmias? Or perhaps I just want supraventricular arrhythmias. Or maybe I want individual terms. I may not want them all. So I've done that to show you what I meant, but I'm going to clear it just so you can see again. So I would come here and I would browse around and I would decide, have I got inclusion or exclusion criteria? How do I really understand the condition? And it may be that I don't do such a broad dump of the terms, that I'm more particular. And I might say, well, I want atrial fibrillation, right-hand click, add it to the research bin. And there I've got an individual preferred term. Atrial flutter potentially, again, add that to the bin. So I can pick out individual preferred terms based on my understanding of the condition. Or I could say, if I had an inclusion criteria and I was focusing, I only want supraventricular, I could do the same again, add selected levels. But I only want the PTs within that HLT. And there they are. I've now got atrial fibrillation, atrial flutter will be in there twice because I've put them in already. That doesn't matter. The system will sort it. So I can either choose individual PTs or I can choose the HLT, the HLGT, but as that's what I meant by we could use them to help us think about using the grouping terms, but just to help us identify the terms we want. But I'm going to build my basket at a PT level. It's like online shopping. That's the way I think of it. When you put something in your basket, then you check out. So the starting point is the diagnosis of an arrhythmia, and I would go through this and I could either pick out individual terms, I could pick out if I have a particular style, a type of arrhythmia, as I say, either supraventricular, cardiac conduction, or I could pick out individual terms and add them to the bin one by one. And you would spend a lot of time doing this. We don't have time today to go through them all, but we can see, and we can see the coloring here that I've opened, for example, rate and rhythm disorders not elsewhere classified. So these are arrhythmias which don't get classified into another HLT. Fetal, for example, bradycardia, cardiac fibrillation, the red ones are uniaxial. They're only in this one sock. This is primary, of course. The blue one, this is the primary sock because bradycardia affects the heart. So this is the site of manifestation. And the green are primary elsewhere. So the green ones, that what we're viewing as a secondary sock, Marshall-White syndrome, I don't know off the top of my head, but I imagine it's possibly a congenital disorder. Oh no, it's a skin problem. So we can see that that's primary to skin, but it does have cardiac manifestations. So some of the syndromes you'll see turn out to be somewhere else. The same here, Ogden syndrome. Let's do the same with that one. What's that? One's primary somewhere else. That one is primary to congenital, as I was saying. Many of these syndromes are primary elsewhere. So we can add them to our bin, even if they are primary elsewhere. I can do a right-hand click on them, add to the research bin, even if they are primary elsewhere, secondary location. So, but what I might want to do is to go to some of the secondary locations and look around so that I'm capturing all the preferred terms that could be used for coding a patient with an arrhythmia. So I would spend time looking there at the diagnosis. I'm just going to close the bin for a moment so I can do a query here. Let's type it in, do a bottom-up search, arrhythmia, and see, are there any other terms? I could look through these. Maybe I've missed some which are actually primary and located in a different sock. So I could have a look here. Pacemaker generated arrhythmia, for example. This is one which we can see there is actually in the general disorders and administration site conditions. So this one, it does have a link into cardiac, and we may have seen it there with a secondary link. That's our basket. Let me move that one over. But I can either search in the top down in the hierarchy, or I can do a search bottom up. And when I find a PT, so again, I can click on I can toggle to the PT list and have a look at those. Neonatal, pacemaker, let's check, are there any that I haven't picked up in my top down search? And if I find one that I have missed, I can add it to the research bin from that screen as well. So either on the left-hand side, top down, or right-hand side, bottom up, we can type them in. So we get our diagnoses that way. Then let's think about symptoms. What type of symptoms would a patient have if they've got an arrhythmia? Well, they're probably going to have palpitations, aren't they? And maybe they're going to they might faint. They might be breathless, arrhythmia. So let's have a look. So what we've got, have we got in the cardiac sock, we've got an HLT of cardiac disorders, signs and symptoms. So let's have a look in there. Cardiac signs and symptoms. I can have a look down. Which of these? Cardiac discomfort? Yes, that's possible, depending on how the patient has described it. They may not have said palpitations. They may have said, I've got discomfort. Dizziness, or they might be dizzy. Yes, very much so. That one's green, because if we think dizziness is a, I'll add that one to the bin, dizziness. Cyanosis is blue. Extremities, no, not really. What else might? Palpitations, there it is. Palpitations, add that to the bin. Pre-syncope, feeling faint, possibly, more likely fainting, but I could add pre-syncope, feeling faint, fainting, pre-syncope and syncope. So these are all in the nervous system disorder SOC. That's why they're green, fainting and the dizziness. So I could go along to the nervous system SOC and have a look and see if there are others there. Then dyspnea. Well, dyspnea is a respiratory symptom, but it could be indicative of cardiac. That's why majority of these are green. So dyspnea, yes, the patient could be dyspneic. Add it to the bin. Again, that's in the respiratory SOC. So I could go and have a look there. Paroxysmal nocturnal dyspnea. No, that's more of a heart failure. We don't want that one. Let's do arrhythmias we're focusing on. So we have a look down. I can do the same here. The other thing I can type in, let's close this. I can type in if I think somebody may even have a cardiac arrest. So let's have a look at that. It might be the first we know about it is that they sadly have a cardiorespiratory arrest, cardiac arrest. There it is at the PT of cardiac arrest. So I can do the same here. Look at the PT toggle is probably easier. Add it to the bin. And what I can do, go back to there, I can go to browser. So I found the term cardiac arrest. Now that is in the ventricular arrhythmias and cardiac arrest. So I could have a look at that one and see. There's all the LLTs underneath it. Yeah, cardiac arrest neonatal. Well, unlikely, but I could. Cardiac death. The first we know about is it might be a cardiac death. Excuse me. That one's green. The reason that one's green, and it's reminded me that we do need to capture all the death terms. So this is something to bear in mind. The first you know about it is that the patient may have died. So let's go to the general disorders. That's where all the death terms are. And let's check if there's any other terms. So because I found it, I could see it was the secondary SOC. So fatal outcomes, all the death terms in MedDRA are grouped together. So I can have a look there. Cardiac death, look down, any others? So I think I put that one in. Sudden cardiac death is a separate PT, so I can add that one to my bin. So we need to make sure we think about all the possible SOCs. So we've got our diagnosis, we've got our death terms, symptoms. We've added some symptoms, but let's go down to the nervous system where we saw the others. So nervous system disorders, let's think about symptoms from there. Central nervous system. So we need to think through now. Nervous system, we want the signs and symptoms really. So neurological disorders not elsewhere classified. Let's have a look there. That's more likely to have the general symptoms, neurological signs and symptoms. Agitation, brain fog, no. Crying, no. Dizziness, there's the dizziness. We see it's blue here. This is because it's the primary location, so it's shown in blue. It's green in the cardiac SOC because that's the secondary location. So I put this one in at the top, but I could have put it in from here. It would work exactly the same. I don't need to do it twice, but I'm just showing you how to do it. Head discomfort, no, I've got that one. I'm not seeing much else here. Neurological symptom, there's the presyncope. Procedural dizziness, restlessness, no. So you see, we've got quite a lot there. We've got some of these already. The syncope we've already got, dizziness we've got, dyspnea we've got. What about something else, like a general symptom, like just consciousness? Let's look at consciousness. Delayed consciousness fluctuating, altered state of consciousness, maybe. That might be how it's reported. Depressed level of consciousness, possibly. Loss of consciousness, definitely I'll have that one, because that's how it might be reported, not necessarily as a fainting or syncope. It might be reported as loss of consciousness. Somnolence, well, somebody might be, there's the syncope, somebody might be drowsy, they might be sleepy more than drowsy, but I could add that one. They might be tired, they might be fatigued, breathless we've already got. So let's go back. I'm in conscious of time. Let's go back here and let's say someone might be tired, they might be fatigued. So let's look for that one, fatigue. And there, let's go PT. It's easier to go PT. There's the PT for fatigue. Add that to my bin. So you get the idea. We've got our symptoms. We've added that. We've got our diagnosis. Remember now we need to do the investigation results. So we need to do our lab results. This is going to be very important because with an arrhythmia, there's going to be ECG results. So we go cardiac and vascular investigations, ECG investigations, and this is going to be a very important SOC, HLT here. We need to pick out all the abnormal terms that could be used for coding of an abnormal lab result. We can't add the whole HLT because it includes normal and abnormal. So we'd need to go through and add all the various abnormal ECG. And depending on how I define the condition, I might be interested in specific types of ECG results, depending on how I spent time. As I say, you would spend time doing this, but you would look through, you'd find all the investigation results, and then you'd go through anything that could be indicative of an arrhythmia. Then the procedures. Let's go to the procedures. What procedure would be done for an arrhythmia? Well, surgical and medical procedures. We would look here, cardiac therapeutic procedures, not elsewhere classified. Cardiac ablation, yes. They might do to the node to stop cardioversion. Another one that I see, there it is, add that to the bin, cardioversion, shocking a patient back into normal rhythm. So again, we'd go through, we'd look at any others. We'd go through that carefully. I've added a couple to give you an idea. Might be that a pacemaker is inserted. So cardiac device therapeutic procedures. Cardiac pacemaker insertion, add that. Implantable defibrillator insertion, it might be that. So we'd look at the investigations, the surgical medical procedures, and let's not forget the other SOC, which is non-multiaxial, the social circumstances. So let's go back to social circumstances and let's have a look if we've got any under lifestyle. We've got disability issues. And let's have a look. Cardiac assistance device user. Well, what comes under that? Pacemaker comes under that. Defibrillator comes under that. So cardiac assistance device user, there's the PT, always choosing the PT. I just use the HLT and HLGT to navigate, and I can have a look. Are there any others here which could be relevant to cardiac? Unlikely. but I would spend time. Artificial heart, no, not really, not for a arrhythmia. So I'd have a look through and check I've got everything. When I'm happy, I've been through, I've done the death terms, I've done the symptoms, done the diagnosis, done the 3 non-multi-axial SOCs, then I would be happy. I could give my basket a name, arrhythmia, and I can give it a date if I want to, although that comes out any information I want. And then when I'm happy, I can review it here. I can review any that there's one there I've got any that I've got twice. Some of them are twice because it's the secondary SOC, the primary SOC and the secondary SOC. As you see here, Ogden syndrome, you saw I put it in from a secondary SOC location. It gives me all the placements for that term. And when I export, I have the option here at the top. Do I want to see the secondary SOCs in my export? So if I uncheck that and I just export, I'm only then exporting the primary SOC locations. Do an export. There it is in my downloads immediately. And I'm going to, there it is. So in Excel, I now see I've got the PTs only in their primary SOC, and I could give this to a colleague to run in a query tool for me against a database, a clinical trial database, or a safety database, looking for patients who've got an event coded to any one of these. So that's the way I do it. So let's go back to our slides. So we've done it in real. The starting point was our cardiac arrhythmias, top down. Then we also did bottom up, and we looked at the non-multi-axial SOCs. So we've got investigations under ECG. Oh, we didn't do heart rate and pulse, but we could have done, and we'd have found their heart rate irregular. Then we looked in surgical and medical procedures. We looked at the cardiac device therapeutic procedures, defibrillator insertion, cardioversion. And there's a note on this slide that when they built the SMQ of cardiac arrhythmias, they didn't actually include the pacemaker and the therapeutic procedure terms because they found it was giving too much noise. So they decided not to. They decided the likelihood is the patient would also be reporting a symptom. So we'd pick up the patients through the symptoms. Here are some of the symptoms, and these are the places we looked when we did our demo. You've got it there for reference: palpitation, shortness of breath, chest pain. We didn't have chest pain in our list. And lastly, don't forget the death terms, which we found those. And they were in the general disorders with a secondary link into cardiac. So we did all that. And if we were to give that list to someone running against the data set, here I have 10 patients, and you see there in the second column, the events reported for those patients. I've run it and I can see there, have I picked them up or not? Well, the second patient had a sudden death, so we would have retrieved them. They are a potential case, but we need to review them. Just because somebody has a sudden death doesn't mean it's necessarily due to an arrhythmia. Then coming down, next person had an electrocardiogram abnormal and a cardiorespiratory arrest and dyspnea. So I think we had all those in our search. We certainly had cardiac arrest. We maybe would have put cardiorespiratory arrest as well. That again is a potential case that would need to be reviewed, and you get the idea. So we're aiming to retrieve all the patients that are potential and not others. We don't want to retrieve irrelevant cases, because the wider we throw our net, we're going to retrieve more patients, and we may get patients who don't have arrhythmias, and it's going to be more work for us reviewing the patients individually. So that's why we want to be as focused as possible. And it may be that when you build a query, you build it, you test it on your data, and you might adjust it. It might be an iterative process where you remove some of the PTs if you find they're not retrieving, relevant cases, or they're bringing back a lot of irrelevant cases, you might think about refining your search and running it again. So you do need to set aside quite considerable time for these kind of searches to build them correctly. So I was going to do another one now for you. So for you to have a think now, if we were looking, we've done arrhythmia, but what if we were to do cardiac failure? Could we build a query with a set of preferred terms relevant to the condition of cardiac failure? Now, what signs and symptoms, diagnoses, investigations, or procedures do you think we would want to include? So you think it through, you type them in, and then I'm going to put them, before we close, I'm going to put your suggestions in a spreadsheet and see whether we can retrieve some relevant cases for cardiac failure. So you tell us what signs and symptoms or what diagnosis terms do you think we would want to include for cardiac failure? Cardiac failure. If somebody's heart is not beating efficiently, if it's failing, if it's weak, what symptoms would you see? What are we seeing here? Tiredness, yes. Pale skin, sweating, dyspnea, chest pain. I'll give you a minute or so more. Edema, we're seeing a lot of edema. Any particular edema? Paroxysmal nocturnal dyspnea, lovely, thank you. Heartburn. They might describe it as heartburn, mightn't they? If they're having a problem, chest pain due to cardiac, could be reported as heartburn. Arrhythmia, somebody's giving us that one. Less likely, I think, if their heart is, it might be the cause, potentially. Chagas disease, is that an underlying cause for heart failure? Remember the procedures as well: collapse, diagnosis, signs and symptoms, dizziness, somebody says. Irregular heartbeat is more of a arrhythmia. Coughing, productive cough, somebody says. Yes, they might have pulmonary edema or pulmonary edema we could have in our list. Fluid on the lung might cause them to cough up frothy sputum. Breathing problems, yeah, it might be reported not as specific as dyspnea. Breathing problems. Dyspnea we can put on our list as well from that, the preferred term of dyspnea. Remember, we're going to put the PTs in. Angina, somebody says. Sweating. Tiredness. Ascites, there's the fluid retention coming in. If the heart's not beating correctly, fluid's going to collect in places it shouldn't. So fluid retention. In the ankles as well. So why do they get peripheral edema? Lovely, thank you. Somebody's put that one there. Peripheral edema. Now we need the PTs associated with these. Exertional dyspnea. Leg edema, exercise intolerance. Again, with that tiredness, isn't it? Again, exercise. So you get the idea how many terms there are that we need to. Hepatojugular reflex. Reflux, isn't it? Reflux. EcoScan. That must be the procedure. That sounds like a trade name. Can you give it us? MedDRA doesn't have brand names, so if that's a particular type of scan, maybe you could describe it for me. Something like ejection fraction maybe would be a test. Ejection fraction, potentially. Ejection fraction decreased. Checking the cardiac output. Cardiac output even decreased. A lab result, Headache, that's quite general. I'm not sure. You may have a headache, but you're going to retrieve a lot of patients. So remember, you want to be as specific as you can be so that you don't retrieve a lot of irrelevant patients. So be careful of very broad symptoms like headache. Weight gain, yes, because of fluid retention, they might have weight gain. So in the interest of time, I'm going to close the poll and I'm going to show you how we want to get these into a spreadsheet. So how am I doing on time? I've got 5 minutes. So let me put them into the browser. So I'm going to clear my basket. Right. So now I'm going to put these into some of the ones you showed me. Cardiac output decreased. Preferred term, cardiac output decreased. I'm going to add this one to my research bin. Close it. Peripheral edema. So we want the PT. So there it is, edema peripheral. Add it to the bin. Close the bin. And then paroxysmal nocturnal dyspnea, you told me. So let dyspnea paroxysmal nocturnal. Dyspnea paroxysmal nocturnal. Add that to my bin. Fatigue. Tiredness, I think you said, didn't you? Fatigue, PT. Add to the bin. I'm going to group some tiredness. Let's see if it is. I think it comes under the same. Let's have a look. Yes, it comes under the fatigue, PT. Hepatojugular. Let's look for that one. Hepatojugular reflux. There it is as a PT. Add to the research bin. And so you get the idea. So you would do weight gain, abnormal weight gain. We might have a weight increase. We might do fluid retention, ascites, somebody mentioned. So let's search for that one. Ascites, the PT for ascites. Add it to the research bin. I'm conscious of time, so I'm going to add a couple more. Ejection fraction. Ejection fraction. It might even be a transplant if somebody's heart was very weak. We didn't get onto that one, but we might even ejection fraction decrease. So remember, we need to make sure we select the lab results which have the qualifier to show whether they increased or decreased. What was that? A heart transplant. If you're thinking of procedures for heart failure, at the extreme case, it may be that the patient has a heart transplant. Add to the research bin. Sweating, peripheral. I'm trying to put in the key. Somebody suggested Chaga. We can put our Chagas disease in. That's my last one for now. And Chagas disease. Oh, LLPT. Let's put congenital or gastrointestinal. Well, because there isn't one, I'm not going to put one in because of the PT, because we're looking for heart. Doesn't look specifically heart. EcoScan, I don't think will be in MedDRA because it's a trade name. We'd need to have the type of scan. So we need to find the PTs that capture the symptoms, the diagnoses, the lab results, anything we have there. So we've got them in our basket. I'm going to now go to show my basket. So show my research bin. There's my research bin. I've got a few in there, not as many as you gave me. I'm going to give it a new title of heart failure, and I'm going to export it. So then I will have a nice neat list here of preferred terms. Oh, it's taken them in LLTs. I don't want them in LLTs. I want them as PTs. But I would have them as PTs, and I would run them against my data. Now I have a sheet that I did earlier just in case we didn't have time. So I've got a quick failure here. So this includes some of the ones you gave me, some of the names of conditions. We needed to make sure we've got congestive cardiac failure we needed as the diagnosis. So here they all are. So here's one I prepared before we came along, and I'll just paste that. So there we go. So I could take this. Now I've got a spreadsheet here. So what I'm going to do, I've got a spreadsheet just to show you as an illustration. I'm going to put them in here in my spreadsheet, and you see some of them have changed color. Now I've got a spreadsheet just purely for illustration to show you how you would run it in a query tool, but I don't have a query tool. So I've got Excel with a macro. So I'm just going to show you. Imagine we've got a small data set with some patients, and we can see here which preferred terms we had in our list, how it matches the patient events. If we look at column B, patient 1 had nausea, vomiting and diarrhea. They are unlikely to be a case of heart failure. We didn't retrieve them. We didn't need to retrieve them. That's good. The second one had a PT of heart failure in the coding. So they are a potential case. We needed to review them, and we would have retrieved them. The next one, I don't know why, paroxysmal nocturnal dyspnea. We had this in our list. They are a potential case. We would need to retrieve them. So I didn't have that in the list I did earlier, but you gave it to me. Cardiac congestive hepatopathy, again, is potential. So you get the idea. So we're making a list of preferred terms that allow us to retrieve the patients. This patient here had a heart transplant. This patient here had a ventricular assistance device insertion. So again, showing you the list that you want to build, all the possible ways that heart failure could be reported. So that, let's move on then. So we've done that. So as we see, wrapping up then, MedDRA is a powerful tool for data retrieval, but it needs solid medical knowledge and MedDRA knowledge. The size and complexity of MedDRA overcome the lack of specificity, but may require a more creative approach to data retrieval. So it is well worth the effort to develop, share, and store these in-house queries. This is what we've covered today. I'm sorry, I realize I've overrun just slightly, but I'm happy to stay if you've got questions. We've discussed topics in the data retrieval and presentation points to consider document. We've discussed applications of MedDRA in data retrieval, presentation and analysis, and we've discussed and demonstrated the use of MedDRA for developing queries. Here are some useful links for you to the website. I showed you on the website where you could access the browsers and the MVAT tool. I'll also now, just while Leander's checking for questions, I'll go to the browser and I'll just show you where you can also find the documents that we mentioned. So under how to use support documentation, we've got there how to use support documentation. We've got the points to consider documents, and best practices guide goes under the blue banner at the top. This is because these documents come out annually and some of them are just updated as and when needed. So they don't fall under a particular version banner. They go under the blue banner at the top, MedDRA term selection, points to consider, and data retrieval and presentation, points to consider. 3 formats. So if you want, you can incorporate them in your SOPs, you can adapt them. There's a navigable online version, as well as having a Word and a PDF version. And we can see that. And then within each release of MedDRA, that's where you have the introductory guide to MedDRA and the other documents, the SMQs that we'll talk about next week. So here we have that. So that's just something I wanted to show. Any questions, Leander?
We had a couple of questions, Jane. We had one that said, sorry if I missed it, but please can you explain why some of the terms are highlighted in red again? I did mention about the legend that explains all of the colour codes that we use, but I wonder if you demonstrate where to find it.
I think you mean in the spreadsheet, don't you? Why are some of the terms green and some of the terms... No, in the browser, you mean?
It was in the browser when we were in the browser earlier.
Oh, okay. So there's a legend in the browser. So the preferred terms are color coded. I'll open the legend. You can open it from the top corner, legends. The red term means it's only in one sock. It's uniaxial. Only in one sock, this is primary. The blue terms are in multi-axial. They are in multiple socks, but what we're viewing as the primary. And the green means that the preferred term does fall into multiple socks, and what we're viewing is the secondary sock. So we're in social circumstances here, and because that we know that the terms are all only in that sock, that's why we're seeing they're all red, primary, uniaxial. But if we were to go back to the cardiac disorders where we were, we could see that some of those terms, if we go to the symptom, signs and symptoms, I showed you, didn't I, the nervous system disorders like dizziness. Dizziness is green, and if I put my cursor and show you the details, occurrences, we see there on the right hand side it's primary to nervous system. So when we saw dizziness in the nervous system sock, we saw it was blue, but here we're in the cardiac sock, which is one of the secondary sock assignments for the preferred term dizziness. That's why it's green.
Thanks, Jane. And what is the appropriate method for reviewing your Excel table to identify updated PTs in the upcoming version of MedDRA?
So when you have your spreadsheet, I'm not sure if I kept it out or not. When you have your output from MVAT, I've closed it, sorry. When you have your list of new preferred terms, you would review it because you need to know your product and you need to know what queries have you built for your product. And if there are any queries that are for a condition and you see new PTs relating to that condition, that's where you would need to consider adding them to your query. I can't give you an automated approach or a way of doing that. It's up to you to manually review them and know what's in your query. So the best thing I would give you advice is when you build your query, write down for yourself, for your own reference, how you went about it. What was your thinking process behind building that query, so that when you see the terms in the new preferred terms in the new terms list, then you can you can think, oh yes, I looked in this location, I looked in this HLT or this SOC or this area, and then you can hone in on the preferred terms with that placement when you're reviewing the list. Otherwise, I'm not sure what tips I could give you to review them.
Thanks, Jane. And just a general question. When we start a study using a specific MedDRA version, is it recommended to keep the same version until the end of the study or to keep updating the version while the study is ongoing?
So the best point I can point you to for that is the MedDRA best practices document, and it explains that in detail. It gives you different approaches. So if we have a look at the index, it gives you recommendation for clinical trials, the different ways that you possibly could do it. There are different options, and it talks you through all of them, freezing at the start of the project or at the start of the study, updating every 6 months. And it does tell you that option 5, which is freezing at the beginning and updating at the end, or updating every 6 months, these are the recommendation. The MSSO recommends option 5 or 6. Ideally, every 6 months is the best approach, but if you can't do that, then update at the end of the study.
That's great. Thank you, Jane. And we've answered all the questions. Thanks, everyone, for all your questions. It does make it much more interesting and helpful, I think, for everybody who's come on the training. And we've had some lovely feedback that the training's been extremely helpful. So thank you, Jane.
Sorry I overrun, everyone, but thank you for your input. Thank you, Leander, for your support today. I'll leave you all there. Enjoy the rest of your day, and I hope to see you next week for SMQs. Take care, everyone. Bye-bye.